Hello. Welcome, Srinivasan sir, Sareen sir.
Hello, good evening, good evening. So, how are you?
Yes, sir, fine. We were all in Goa. We got the Pedicon 2027.
Congratulations. You all brought this thing back to Tamil Nadu, Kauai.
It's all the
Good.
teamwork that
It's a
Rajan.
great thing. Yeah, yeah. So, you're all very powerful people now.
No, nothing like that, sir.
Not really powerful, resourceful, and so many adjectives I can go on telling from A to Z.
Nothing. You're just doing the work, that's all.
So accomplishment A, Z is zeal and enthusiasm.
Okay. That might be there, sir.
Yeah, your team is doing a wonderful job. Only thing I have one request to make, I have mentioned.
Yes, sir.
See, this cell phone, I am not able to transfer this thing, everything is coming, all these drugs.
Okay.
Okay, I'll give you my email address. You kindly send it there.
Sure,
Then I can save it. Okay, you don't mind? Of course, you
no,
are so busy, so I feel
no,
very
no,
guilty to give this
no problem, sir.
work.
Hello,
Uh,
sir.
Good
Devendra
morning,
Saran,
sir.
sir.
Good
Good
evening, sir.
morning. Good
Srinivasan, sir. Very good evening,
For me, it
sir.
is good morning. It is morning for you. Good evening. You
Yes,
are also
good
in
morning.
USA?
Morning for me, sir. New York. Morning for me. I am in New York,
Yeah.
sir.
You have come for your daughter's great
Yes, sir. Yes,
achievement.
sir. Yes, sir.
Yes,
Enjoying,
congratulations.
enjoying,
Yeah.
and lot of congratulations, Narmada madam.
Thank you,
Tamil
sir.
Nadu, Coimbatore, Jalil bhai.
Yeah. Jalil sir was,
All efforts, Jalil bhai.
yeah,
One of the,
congratulations.
yeah.
Congratulations, Jalil boy.
Congratulations, Jalil bhai.
Jalil boy,
Sir.
look so different now. So
Yeah.
already
The
is getting ready
smile
for
on
the
the face, sir.
conference. He's in the
Jalil
plane.
bhai.
Uh, he's
Rajendra,
in
sir.
flying. I know. I can see it, air seat
Yes,
and
sir.
this
Yes, sir. Rajendran, sir. Congratulations, sir. Heartiest
Nehru.
congratulations.
Heartiest congratulations,
Sir,
Dr.
sir,
Rajendran.
sir, sir, sir,
You were
sir.
all,
Sir,
they'll,
they will be 27 will be at Coimbatore, sir. Coimbatore. We'll enjoy the hospitality wonderfully. Okay.
Thank you, sir. Thank you all with your blessings.
And before that, we are coming for the conference also, sir. 13th, 14th, 15th of August.
Thank you.
Yes, sir.
Anna, flight
Hard work always pays, sir. Hard work.
yeah,
Teamwork.
Rajendran and his
Narmada,
team and
Narmada
this thing.
வந்துட்டீங்களா?
வந்துட்டேன் நான் இங்கதான் இருக்கேன் நானு.
அவங்க தான் முதல்ல அங்கே தான் இருக்காங்க.
இங்கதான் இருக்கீங்களா? சரி.
ஆமாங்க. என்னங்கண்ணா 6:15 ஃபிளைட் இல்ல லேட் ஆயிடுச்சா?
இல்ல இதான் கரெக்ட் 6:15 இப்பதான் லேண்ட் ஆச்சு. இந்த ஃபிளைட்ல தான் இருக்கேன் நானு.
அதான் லேண்ட் ஆயிருக்கீங்க இப்போ. ஓகே.
ஆமா, இப்பதான் லேண்ட் ஆச்சு. டவுட் ஆச்சு. ஏன்னா அவரும் திருமுருகனா ட்ரை
லேண்ட்
பண்ணிட்டு
ஆச்சு
இருப்பாரு.
இல்ல,
எப்படி
நல்ல
ஓபன் ஆச்சுன்னு பார்த்தா.
சுகமாக லேண்ட் ஆச்சு
இல்ல
இல்ல,
நான் இருக்கேன்
அதுதான் முக்கியம்.
டோன்ட் வரி.
Srinivasan,
சுகமாக
sir.
லேண்ட் ஆச்சு இல்ல,
Okay.
பார்த்தாலே தெரியுது.
Srinivasan, sir. Jalil,
Yes.
sir, is the hero of the heroes. Hero of the heroes.
Yeah. If I had been a director, I would have cast him in this film.
Welcome, Dr. Shivan Kesavan, sir. Thank you for joining us, our expert for today evening.
Hello, ma'am.
Shivan Kesavan, sir.
Hello, Dr. Shivan Kesman, sir. Congratulations.
Sir, good evening.
Shivan
Thank you
Kesavan,
for having me.
congratulations.
Thank you, sir.
Yeah. Wonderful to see you.
Wonderful.
Nice to see you too, sir.
Yeah, I missed your this thing, Mehta Hospital, this thing. Because of being in USA, I'm missing so many things. Kongu, Padikon, and other things.
Yes, sir.
Anyhow, they are
welcome.
Sir, thank you, sir. Good evening. Thanks for having me, sir.
Okay, put it.
I'll be missing, sir. The ID at Jaipur, sir. I'll be missing that one, sir. Being at USA, sir. In Jaipur.
India by Indigo.
Anyhow, I cannot complain at this age, even this much of this thing, allowances are given for me to attend all these wonderful classes.
Sir, I don't know whether we'll be doing it at your age, sir. I'm just waiting for Sudhakar and Karnakaran, sir. I hope he has joined.
Shivan case one looks a little different. Is it the glass which makes you different?
I have shaved after a long time, sir. Probably that's why.
But looking smart. Dr. Shivam
Yeah,
Keswan
he has
looking
always
smart.
been smart, sir.
Yes,
Right from the
yes.
time I know him.
Thank you, sir.
Welcome, Dr. Ashwath. Thanks for joining. Ashwath, sir.
Good evening.
Good evening. Thanks for joining.
Good evening, sir.
Good evening, sir.
Ashwath, sir, good evening.
Good
Good
evening,
evening,
sir.
Ashok sir.
Good evening. Good
Sudhakar
evening, sir.
Sudhakar sir join பண்ணிட்டாங்களா? Can you call him, sir? A number இல்ல.
அஸ்வத் என்கிட்ட முகத்தை காமிக்க மாட்டேங்கிறாரு. எங்களுக்கு கொஞ்சம் இது வரும்ல, your race will give some knowledge.
Ashwath
I
sir.
don't want to upset you and put you off dinner, sir.
நான் டின்னர் கின்னர்லாம் ஒன்றும் கிடையாது. இப்போ வந்து மார்னிங் டைம். I had my breakfast.
Jalil sir traveling? You're traveling?
Yeah, he's coming back from Goa.
And Singarvelu sir, welcome sir.
Sir, good evening, sir. Good evening.
Heartiest
Good evening.
congratulations.
Sudha, join
Good evening,
Manikriyama.
Dr. Singarvelu, sir.
Sudha, join Manikriyama.
Thank you, sir. It's all collective effort, support by all.
Yes, sir.
Our Tamil Nadu was able to make it.
Yes,
Thank
sir.
you.
Yes, sir.
Congratulations, congratulations.
Congratulations, sir.
Already
Heartiest
conveyed it.
congratulations.
Ashwath sir, Sudhakar sir join பண்ணிட்டாரா sir?
Narmada.
இப்பதான் அவர் கூப்பிட்டிருக்கேன். I've already called.
Yeah.
Good evening,
Ashwath,
Singarvelu,
Narmada,
sir.
good evening.
Good evening, sir.
When did you reach Narmada?
Today afternoon, sir, I came by around 1 o'clock to Vellore.
Okay, good.
Morning I took the flight. The flight was
About 8 o'clock. Good 8 o'clock.
Ashwath sir, அவர் ஜாயின் பண்ணிட்டாருன்னா நம்ம ஸ்டார்ட் பண்ணிடலாம்.
Narmada,
Sir,
Dr.
சிங்காரவேலு சார்
Sudhakar is
பார்க்கறதுக்கு
joining.
என்னைக்குமே சிங்காரவேலன் தான்.
Good evening.
உங்களை பார்க்கும் போதெல்லாம் அந்த பாட்டு தான் ஞாபகம் வருது. சிங்காரவேலனே தேவான்னு பாடணும் போல ஒரு ஆசை.
Thank you, sir. Thank you, sir.
அவர் ஜாயின் பண்ணிட்டாருன்னா சொல்லுங்க சார், we can start off.
இல்ல அவர் ஜாயின் பண்ணிப்பார். ஃபர்ஸ்ட் செஷன் டாக்டர் கேஷ்வந்த் தான். We can start.
ராஜேந்திரன் அண்ணா ஸ்டார்ட் பண்ணி.
நர்மதா ஆரம்பிச்சிருங்க. Start.
Hello.
So we'll first on behalf of IAP Tamil Nadu State Chapter, we welcome you all for yet another interesting academic session on Perspective Plunges in Pediatrics for Practitioners. This has been one of the academic programs which has been run continuously along with other programs, and we are very happy to have our esteemed speakers, Dr. Shivan Kesavan, Dr. Sudhakar, and the coordinator of the program, Dr. Singaravelu sir, our academic coordinator, and Ashwath, our coordinator for the same, and along with our president, Dr. Rajendran sir. Before we start this program, we will have the pediatricians praying. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, and amidst all people. With all the office bearers coming off from a victorious spree at Goa, we have got the Pedicon 2027 National Pedicon at display of team spirit, and after 21 years, we have got it for our nation. So the leader who guided us all and took all the efforts to get it to and made this task possible, Dr. Rajendran sir. I think he is also coming back from the trip. So I request if he'll be able to talk a few words to welcome the gathering. Anna muted arkingena.
Thank you, Narmada, and respected our President 2024, Dr. Balashankar, and the President-elect Somasundram, Dr. Narmada, our Honorary Secretary, and Treasurer, Dr. Rajkumar, or our scientific advisor, Dr. Singarvelu sir, and today's program coordinator, Dr. Ashwath sir, and speakers like Shivan Kesavan and as well as Sudhakar Karnagaran. And on behalf of IAP TNC, I welcome one and all. it's a great pleasure and privilege to announce that we have won the National Pedicon bidding after 21 years. I thank each and every one of you to make this possible, and we can proceed the meeting. Thank you very much. Thank you.
Thank you very much, Rajendran sir, for joining
Thank
us.
you. Thank you. Thank you.
Thank
Thank
you.
you. Thank
Now
you.
I request our academic coordinator, Dr. Singarvelu sir, to say a few words.
Thank you, Dr. Narmada, Dynamic Secretary, President and President-elect, past President, and Aswath, and today's speakers. And today, whole Tamil Nadu IAP is in a very important after achievement, a historic achievement under the leadership of Professor Dr. Rajendran and as the Secretary Narmada, and the whole team worked together to reach this high level where the whole India of national level IAP is talking about Tamil Nadu. That to that level, with all the support of our leaders and our one voice, one nation, like that, our leader has made it happen. In this, we are happy to have this academic P4 program, which is very well conducted by Dr. Ashwath, and today's speakers, Steven Keshavan and Sudhakar, will do extremely well. One of the very common problem which all the practitioners are coming across. I'm sure that I don't stand in between the academics. Wish you all the best. Thank you for giving me this opportunity. Wish you all. Thank you.
Thank you, Dr. Singarvelu sir. Yes, of course, it was a very proud moment for all of us when we stood before the entire executive boards, and we got a thumping victory of about 46 votes among the total 82. This itself showed the belief that the nation has on us. And I'm very sure as a team, we will be able to perform and we will be able to host a National Pedicon 2027 in a very grand manner under your leadership when you will become our president-elect. So having said that, I'll give this the podium to Dr. Ashwath, our coordinator for the program on Perspective Plunges in Pediatrics. So Dr. Ashwath, please give a brief about the program and the speakers. Over to you for further proceedings.
Thank you, Dr. Narmada. I think I should congratulate Dr. KR and the entire team of IAP TNSC and our scientific coordinator for putting up such a united show and winning the bid after 21 years. I'm sure we will not disappoint the rest of the country in showing the IAP TNSC is second to none in putting up a wonderful and united show. Coming to today's program, we are continuing where we left off. We are trying to cover as many practically oriented topics as possible to keep the pediatrician from the periphery as the main hero in today's and all the P4 programs. So today we have chosen two very, very dynamic and young neurologists, Dr. Shivan Keshavan and Dr. Sudhakar Karnakaran, both of whom have a DM in pediatric neurology and are extremely competent and very well versed in their fields. And today we have chosen, because pediatric neurology is a very large topic, we have chosen a lecture session on seizure mimic disorders for the first half an hour, followed by a 1 hour interactive session wherein pediatric neurology issues very focused on seizure in OPD practice and approach to headache will be discussed. Over to Dr. Shivan Keshavan. He has done his MBBS from Madurai Medical College, followed by MD and DM in pediatric neurology from PGI Chandigarh. He is currently working as a consultant pediatric neurologist at Mehta's Children's Hospital in Chennai. He is no stranger to the field of APTNSC. We have all been impressed by his immensely practical and very easy, laid-back style to delivering excellent information in a very, very casual manner. We welcome you, Dr. Keshavan and Dr. Sudhakar, and we hope we'll have a meaningful interaction over the next 1.5 hours. Over to you, Dr. Keshavan. I'll introduce the next speaker and the co-panelist, Dr. Sudhakar, at the end of this guest lecture. Thank you. Over to you, Dr. Sudhakar.
Thank you,
Sorry,
sir.
Dr. Keshavan.
Thank you, sir. Good evening, everyone. I thank the office bearers and the conveners and scientific advisors of this session for this opportunity and for the IAP TNSC's vision for providing such good educational programs to pediatricians. Sir, if my screen is visible and if my voice is audible, let me start. Can someone please tell me?
Very well, sir. Very well visible,
Very well
audible.
visible and audible, sir.
Thank you, sir. So in the given 30 minutes, I'll try to cover some common seizure mimics. You know that there are many seizure mimics which we see in common practice, in a pediatric practice. I have chosen those with video representation so that it would be a useful take home for the practicing pediatrician. I'll try to be on time. I'll try to finish before time if possible. So this is a bar chart from Nelson's textbook of pediatrics, which shows that there are many seizure mimics which we see in children. And this is the age-wise split up, which shows that certain disorders or certain phenomena are common in certain age groups. As you can see, jitteriness and benign neonatal sleep, myoclonus, hyperexplexia are all common within the first few months of life. Whereas alternating hemiplegia, infantile masturbation, benign myoclonus, and breath holding spells are common in the second half of infancy. And there are certain disorders such as tics and paroxysmal non-epileptic seizures, which are common in around in children more than 5 years of age. And there are kinesogenic dyskinesias or kinesogenic choreothetic movements, which are more common in children in the second decade. So this is a chart which spans the whole spectrum of disorders according to the age group. So one way of splitting them up or grouping them is based on this semiology, as we call in neurology, the type of movements. So they are classified as generalized paroxysms, movement disorders, oculomotor abnormalities, and sleep disorders. So among which I'll be focusing on the second and the third group, that is the movement disorders and oculomotor abnormalities, because one, they are common. Second, they are a means of confusion among pediatricians in general. And the third important reason for choosing them is that they're visually represented. We have videos of patients with these problems so that you can readily identify which one are these. However, I will briefly talk about certain generalized paroxysms because among the four groups, this is the most common group, I would say. Breath holding spells, reflex anoxic seizures, syncopes, and pseudo seizures. So I'll briefly talk about them as well. So syncope and seizures, how to differentiate? So this is one very common question which postgraduates ask us. And sometimes it is very confusing for pediatricians as well as pediatric neurologists. So this is a general principles on based on which we differentiate seizures and syncopes. So syncopes usually have precipitating factors such as a child who is dehydrated, a child who has not been fed, the child who wakes up in the morning with a high-grade fever causing dehydration and postural tendency for postural, vasovagal syncope. So the precipitating factor is very common, and there are prodromal syndromes, some symptoms which a patient experiences, a child experiences, such as blurring of vision, lightheadedness, some fullness in the ears, some tinnitus, some feeling of nausea, and the posture is invariably standing or a change of posture from lying to sitting or sitting to standing. And the duration of the event, most importantly, is a few seconds. If you very carefully look for the history, the duration is usually in a few seconds the child recovers his baseline level of consciousness, and the episode consists of sudden loss of consciousness and loss of tone, whereas in a seizure, before the loss of tone or an increase in tone, you have a staring spell for a few seconds to minutes before the fall. So these are some clues you can elicit if the video is available of the event, but in syncope it's very brief, so we don't have the video, so only a carefully or a observant parent can give you this information. And most importantly, syncopes do not have a post-event or a post-ictal state, whereas a generalized seizure usually has significant drowsiness for minutes to hours. A syncope is all over in 1 or 2 minutes. So the second event, which again is common in pediatrics but less common than syncope, I would say, is a reflex anoxic seizure. So this happens sometimes in patients with breath holding spells when the breath holding spell lasts for a longer period. So usually breath holding spell consists of a child who's crying, who is emotionally upset and is crying, and suddenly the child becomes cyanosed, the child stops breathing, the child is limp, and the child becomes normal. So this is a usual course of events. There is no post-event period in a breath holding spell as well. But sometimes when the breath holding spell lasts for a few minutes, it becomes a reflex anoxic seizure because there is anoxia to the brain, and the brain, as you know, cannot withstand more than a few minutes of anoxia, and the brain goes into shutdown. The child, faints after this, and because of the anoxia, the child can throw a brief seizure-like event. So these are called reflex seizures. These are true seizures, but this is due to anoxia, not a primary phenomenon occurring in the brain. So the child has a loosening of tone, a loss of muscle tone initially, followed by tonic posturing. Usually in a seizure, you see that tonic posturing occurs first, followed by clonic movements if it is going to be a generalized tonic-clonic seizure, and then the child, goes into unconsciousness. So a child who's crying suddenly stops breathing, loss of tone, and sudden brief posturing. You can also have some minor, myoclonic or clonic movements, some jerky movements, which are very brief, and the child quickly again recovers his baseline level of consciousness. Only a few minutes is the postictal period, not for more than 5 minutes or more than that, which we see in after a generalized tonic-clonic seizure. So this is a reflex anoxic seizure, which sometimes can follow a breath holding spell, which causes confusion whether it is a seizure or not. The third category, which we see in older children, is a paroxysmal non-epileptic seizure. So it's a pseudo seizure. It's also called a pseudo seizure. I'll show you through a few videos how these pseudo seizures can be diagnosed with certain clinical handles. So the general principles in pseudo seizure are: one, the eyes may more commonly remain tightly closed, and the movements, when compared to a true generalized tonic-clonic seizure, are axial predominant. That is, the neck and the trunk move more than the limbs. And there are no true autonomic symptoms. That is, urinary and fecal incontinence and cyanosis are more reliable symptoms than drooling, because a child can fake drooling with voluntary production of saliva. The child may converse, may not lose consciousness fully during a seizure, whereas it is very uncommon, that is unusual, or almost never would we see a generalized tonic-clonic seizure, child who's seizing with a generalized tonic-clonic seizure, not lose consciousness. Sometimes a child may react to a loud noise or a startle stimulus during an apparently generalized seizure, which finally, gives us the idea that it is not a seizure after all. The child generally has bizarre movements, that is side-to-side movements, which is not very commonly seen. The head nodding in a true generalized tonic seizure is a yes kind of a head nod, not a no or a side-to-side head nod. Anatomically, implausible progression. There's something called Jacksonian march, which we see in a focal seizure which generalizes. When the pattern is non-Jacksonian, as I'll show you in a video in the next few slides, we could suspect a paroxysmal non-epileptic seizure. And out-of-phase limb jerks, meaning that a child who has a seizure, when he has clonic jerks of the limbs, all the limbs move in phase together. If one limb moves and there is a time period of a gap between movement of one limb and the other limb, one clonic jerk and other clonic jerk, then it is called an out of phase movement, which again points to this diagnosis of a pseudo seizure. Vocalization is quite common in children with pseudo seizures. Children are usually emotionally distressed, so they have an outburst of emotional content in the form of crying, weeping, yelling, screaming, something like that. Sometimes it is again inducible, which I'll show in a video, and there is no significant postictal period, but the event per se can go on for minutes, hours, and even there can be multiple and keep going on for a long time. That even in children with very refractory epilepsy, in children with cerebral palsy and epilepsy, in children with genetic epilepsy, we see that even though they can have prolonged seizures or frequent seizures, most seizures are over in 1 or 2 or 3 or 4 or 5 minutes. They don't go beyond that. Whenever an event goes for hours, 30-minute seizure, 40-minute seizure, particularly when they are frequent, one should suspect this kind of movement. So I'll go to the videos. So this is a child again evaluated for supposedly refractory seizures. If you can see the audio, you can see the child is emotionally making some noises. Yeah, the eyes are closed, the child is screaming, and you can see the movements are more axial, not much of limb movements. The movement is more of trunk, and there is some hyperventilation and sounds. So again, this is a pseudo seizure. So the clue in that, the first video was that the child was having emotional vocalizations, and the eyes were closed, and the child had more of axial movements, and the events used to go on as long as the parents would see. And when the attention was diverted, the events would rather stop. So these again are children with pseudo seizures. You can see that this is a child, the same child, the video made in two different views. So you can see that these are out of phase movements. One leg, one hand, not at all anatomical. And you can see the head nodding here. The head nodding or the movements are side to side rather than the yes kind of a head nod. So this is again a soft pointer towards the fact that this could be non-epileptic. So this you can see very clearly in this video, which was done at a close proximity. The camera was kept at close proximity. You can see that the child is having a no kind of an head nod, and the child is trying to look at you very briefly. You can see in a generalized seizure, the child wouldn't really, look at you. The child is trying to see and then continues the movement. And the rate of these clonic movements are very slow. In a generalized seizure, at least you will have a 1 Hertz cycle, that is 1 clonic movement per second, even more than that sometimes. But you can see that the child is moving it at his own, pace. One movement and then a few seconds, and then again he takes his own time and then gives the other movement. So it's like 5-6 seconds between movements. Again, it's a very slow movement. It's not physiological. So this is a third child. The audio here is significant. If you can hear it, it is inducible. The pediatrician is trying to do a knee jerk on him, on a child who's apparently seizing. And once the hammer strikes the patellar tendon, the child starts having jerks. The child is okay now, but now he starts having the jerks. Yeah? Yes. So the child here in this video, the next part of the video, you can see the child responds and follows the commands of the, of the doctor who's testing. I'll just rewind it a bit so that you hear his voice. He is trying to hold, obeys the commands of the examiner. The examiner asks him to, try to sit up with some support, and he eventually does. So with some help, the child is able to sit, look at the examiner, see who's shooting his video and all that. So again, these are pointers towards a pseudo seizure. This is a girl again demonstrating a pseudo seizure. So you can see she has jerks in the left lower limb. She's well aware. And later on, you can see she starts having jerks in the right lower limb. So this is again not a very anatomically plausible mechanism, because the upper limbs are not involved and her consciousness is not involved. She's conversing, she's responding, but she keeps having these jerks, right? So this is something called a non-Jacksonian march. So you know that a Jacksonian march means it has to follow the motor homunculus. If it involves the right upper limb, it has to progress to the right lower limb and then to the opposite side. When it is not going to do that, you can have a generalized kind of a movement with loss of consciousness. It is very unlikely the child has movements of both limbs without losing consciousness. Again, because when both cortices of the left and right side are involved, the sensorium obviously gets affected. So this is again a clue that it is non-epileptic. So we'll go to the other non-epileptic movements or seizure mimics. It's a 3-week-old infant with abnormal movements since 1 week of life. This is quite common. You can see the child is asleep. You can see jerks of sometimes both upper limbs, sometimes both lower limbs, sometimes one lower limb, sometimes all together. Yeah. So this occur in sleep. When the child is woken up, the child becomes okay. So this is a very common phenomenon. I am sure you might have, diagnosed it right now. This is even common in children who are older, but, not as dramatic as that seen in the newborn. So this is a child who underwent a video EEG. He just had 2 febrile seizures. And once the mother noticed at 7 years, he started having these movements in sleep, she was alarmed. She was worried that he started to have epilepsy. So child is asleep. You can see the right upper and lower limb. There's sudden jerking, very quick shock-like jerk, and the child goes back to sleep. The child may be aroused by this movement, but the child goes back to sleep. So these occurs in hundreds and thousands of times in sleep. So this is sleep myoclonus. It's physiological. So in the newborn, it is very dramatic. It is rhythmic, giving rise to a suspicion of a myoclonic seizure, but it is neonatal physiological sleep myoclonus. These occur only in sleep. This can be focal, multifocal, unilateral, bilateral, rhythmic, non-rhythmic. In newborns, it can be very dramatic. So it occurs in clusters in newborns over several seconds, followed by variable interval. It just shuts off for some time, and then again, when the sleep cycles in the lighter stages of sleep, it recurs. It usually starts within the first week of life and diminishes in the second month. It can last up to 3 months of life. Generally, it goes away before that. Waking the baby causes the movements to abruptly cease, and many times these children are loaded with benzodiazepines and multiple anti-seizure medications, and this is going to only exacerbate that because these are going to prolong the sleep stages, and once the child is going to sleep longer, they're going to have more of these movements, and they're referred for refractory status. So this is a 10-year-old boy with abnormal movements of legs, only legs, noted particularly when the child comes back from play. He goes to play, he is okay for 20-30 minutes, and then comes back with these movements and has these movements for 30-40 minutes and then becomes okay. The mother also says that when the child goes to play without having his breakfast, this is more likely to happen. So you can see the movements are of the lower limbs. There is some coriform dance-like quality to the movements. Very few jerks of the upper limbs, but predominantly of the lower limbs. There is some twisting as well, so it could qualify for some dystonia, but it is mostly unpredictable and it is dance-like with a jerky quality. So chorea is the right way to call it, predominantly involving the lower limbs. Initially, this child was referred, seen by many neurologists and psychiatrists, psychologists, thinking that he could be faking these movements or these movements are psychogenic. But this particular pattern of occurring after specific triggers gave rise to the suspicion and led to a diagnosis of paroxysmal exercise-induced dyskinesia. This is a genetic condition triggered by sustained exercise and fasting. The duration can be as much as 30 minutes to even an hour. The movement is primarily chorea involving the lower limbs. There may be some dystonia as well. And this is due to a pathogenic variant or a mutation in the SLC2A1 gene, which codes for GLUT1. You know that GLUT1 deficiency syndrome is a spectrum is a disorder which is a spectrum of neurological manifestations. CSF invariably shows low glucose in the absence of an infection. The problem is corrected by ketogenic diet to a very satisfactory extent in patients with only dyskinesia without any other manifestations of GLUT1, including epilepsy and other kinds of problems. You can try levodopa and acetazolamide, for which they have a decent response. So this is a cartoon showing what happens in this disorder. You know that GLUT1 is responsible for transfer of glucose from the blood across the blood-brain barrier to the brain cells. When this is deficient, there is no glucose entering the brain cells and the brain suffers, particularly during fasting and after exercise. And it is a disorder with a wide range of phenotypic manifestations. When it presents in the newborn period, it presents only with gaze abnormalities. Later on in infancy, it can present with seizures. Later, they can develop ataxia, dystonia, spasticity. In older children like this child, they present with paroxysmal symptoms without any of the previously described symptoms, including chorea, dyskinesia, and temporary weakness. And it is frequently triggered by exercise and fasting. So this is a 3-year-old girl with refusal to walk and irritability for 1 week. You can observe her eyes. You can see a quick movement of her eyes. Now we are zooming into her eyes. She's drinking her bottle of milk. So there are two things abnormal in this child. Just closely observe her eyes as well as her hand holding the bottle. So the eyes are having very bizarre, chaotic, not continuous, something like intermittent eye movements, not following a pattern. Sometimes it goes up and now she drops the bottle all of a sudden and then picks it up again, though very clumsily. A 3-year-old shouldn't have this much amount of clumsiness with her fine motor movements. So there is some jerky, sudden jerky. Again, she drops the bottle. Yeah. So she has jerky movements of the eyes, jerky movements of the upper limbs. A child who's irritable refusal to walk with these symptoms without any other signs of raised intracranial pressure, like vomiting or headaches or any other cause, but the child is refusing to walk particularly, and very irritable, not sleeping, you think of this condition. So this is a part of opsoclonus myoclonus ataxia syndrome, which in 50% of patients is a harbinger of neuroblastoma, which is paraneoplastic, and other 50% it can be idiopathic or it can follow an apparently uneventful viral infection. So opsoclonus in Greek means eye and confusing movement. So the movement is rapid, multidirectional, arrhythmic, chaotic. It can go wherever it wishes to, the eye. It is even present in sleep. You need to observe for 1 full minute into the eye of the patient to find out these movements, because they are very intermittent and very erratic. So the other features include ataxia and myoclonus particularly of the upper limbs. You can see the bottle was dropped many times during those when the video was shot, and there is a severe encephalopathy in the form of irritability, sleep disturbance, not in the usual sense of low sensorium. The sensorium is kind of very irritable and is treated imminently with tumor resection and a prolonged course of immunotherapy. So this is again a newborn infant with these kind of movements. You can see the newborn was okay when he was, untouched. And now you can see the examiner who's making a noise and again trying to remove the blanket, gives a tactile stimulus, and the child stiffens. And on top of the stiffening, the child starts jerking multiple times. Yeah. So the child is very sensitive to touch as well as auditory stimuli. So this is something which is called hyperexplexia. This presence in the newborn period, the most important diagnostic handle is exaggerated startle response to auditory or tactile stimuli. You can elicit with a nose tap test, which wasn't necessary in this child because even removing the blanket under which it was asleep caused the child to have gone into this spasm. So it is due to, again, as it is a pathogenic variant in the GLRA1 gene, leading to glycine receptor mutation. And this is the only potential fatal hypertonic apneic spells which we should be worried about is in the newborn period. If they cross the newborn period unscathed, they generally survive, and they may have other problems such as developmental delay and seizures later on, but this is not life threatening beyond the newborn period. So only thing you have to avoid in the newborn period is apnea, because the laryngeal pharyngeal muscles can go into spasms, and then they can lead to sudden death in these patients. Clonazepam is very effective. If you observe this movement going on, if you want to save the child, you do a maneuver called the Vigevano maneuver, which is just similar to the knee chest maneuver which we do for cyanotic spells, forcibly flexing the baby by pressing the head towards the knees, and this aborts. So this is hyperexplexia. So this is a 5-year-old boy, a very common condition, presenting to the outpatient department. There are two boys. You can see the first boy is watching something on the phone and eating. So he's having head nods to the right side. There is some eye blinking. There are some eye up-rolling, side-rolling. In between, you can see there is some, eye blinking, and the eyes also move from here and there. The child is engrossed in what he's watching. There is a phone in front of his hot box, and you can see the child is unaware of these movements, and the child is also having intermittent eyebrow movements upward. So what are these called? These are tics. The other movements are all okay. The head nodding, the eye blinking is all very common. People easily diagnose it, but the eye movements are frequently mistaken for something else. So these are ocular tics which I want to draw your attention to here. So this is a bigger boy with a high resolution zoomed in video showing the eyes. So again, there is some eye blinking, but rather slow than the previous child, but it is repetitive. And there is some eye side rolling, up rolling, so this is there. So the usually ocular tics do not occur in isolation. If you try to elicit history, you will find the other kinds of facial tics and upper limb tics as well. But ocular tics can be confusing. So tics are involuntary, rapid, repetitive, purposeless, stereotyped, intermittent muscle movements. This can take the form of blinking, winking, eye rolling, or staring. Very commonly, there is a premonitory urge, and they are suppressible. If you ask the child to, sit like a statue for a minute, the child will be able to do. But after that, that period the child, tries to complete all his tics which he had suppressed. Right? There is no consciousness and awareness. A child who's eye blinking and suddenly the eyes roll up, you think of an absence seizure. But an absence seizure cannot be aborted by distracting the child, whereas a tic can be. Yeah, so it is associated frequently with facial, head and neck tics in the form of grimacing, head and neck jerking, and frequently it can be seen in neurotypical children, but it is frequently associated with children with neurodevelopmental disorders, including ADHD and some patients with autism spectrum disorder. So this again is rather uncommon in our part of the country, but it can pose a big diagnostic dilemma. So this is an infant who was referred for refractory focal seizures. You can see the child, the eyes are uprolled, the child is having jerky movements of the eyelids as well as the perioral region. The child is apparently not very well aware, not fully conscious. And you can see the child is awake in the first video. When the child sleeps in the second video, as you can see, the jerks have drastically reduced, though you have very, minimal jerks on one side of the face, but the very fast rhythmic jerks which are present in the perioral and periocular region are not present here. So this is very unlikely to be a seizure. It is contrasted with a true focal seizure in the rightmost video which I am playing now. This is a true focal seizure in a child with a devastating encephalopathy. You can see the child is asleep here, but the focal seizures of the right upper and lower limb, more pronounced in the lower limb, are going on. Right? So this is not a true seizure, but what could this be? This was infantile tremor syndrome. It's a devastating neurological complication of severe vitamin B12 deficiency, very common in the North Indian states of India due to nutritional and child rearing practices. Skin hyperpigmentation, sparse hair with depigmentation, megaloblastic anemia, and developmental delay and regression. In addition to these tremors, these are actually tremors rather than seizures, which are resembling, focal seizures. The fact that this child has sparse hypopigmented hair is a clue, and there is some hyperpigmentation also, which is not revealed in this video. Right? So this is due to infantile vitamin B12 deficiency. B12 is low, and plasma homocysteine is a more sensitive surrogate marker of cellular B12 deficiency, which is quite high. So you know the mechanism. It is due to prolonged and exclusive breastfeeding in a mother who is B12 deficient. So a mother who takes strictly vegetarian or vegan food is very likely to be B12 deficient, particularly when she has children of the second and third order. The third child becomes B12 deficient. So the B12 deficient infant starts having these tremors in infancy that leads to feeding difficulty and refusal of solid food, which again leads to prolonged breastfeeding because that's the only thing the mother can give. So this leads to a vicious cycle. It is treated very well by B12, giving B12, but earlier you find this condition out and treat, the outcomes are good, but it is at least partially reversible even in the worst possible state. So the clue is that these tremors disappear in sleep. It's frequently misdiagnosed. We used to get a couple of cases every month to the emergency, misdiagnosed as focal status epilepticus, and they are refractory, obviously, because they do not respond to anti-seizure medication. The medication which is effective is B12. So these are two children with the same problem. I'll just show you. Again, this is mistaken for status epilepticus, many times coming to the emergency. I'll play both together so that you can observe the kind of movements. So there is twisting, there is opisthotonus, right? And the child has both limbs clenched. Yeah. So there is stiffness, and the first child is quite aware. You can see the eyes. The child is quite aware, not really unconscious. The second child also is aware if you are very observant. And you can see the child is trying to make voluntary movements and move, resisting this involuntary movement, right? So this is not possible in a generalized tonic seizure or a clonic seizure. The child will never be aware. The child will never try to move because the child is totally unconscious and knocked out. So this is dystonia or status dystonicus masquerading as status epilepticus. So dystonia is generally seen in children with predisposing conditions. In these two patients were those of neonatal bilirubin encephalopathy. Frequently it is triggered by febrile illness because This decompensates the child because this is a phenomenon arising from the basal ganglia. As you know, basal ganglia is highly metabolically active. So when you have a fever, they decompensate and throw these dystonic spells. It can be provoked by physical stimulation. That is an important clue. The child is sleeping, this comes down, and child is rested. When you awaken the child by touch or cause pain, the child starts twisting itself with severe dystonia, and there is no loss of consciousness, though it can be very it needs to be very subtly looked for. And most importantly, even after prolonged dystonic spell lasting for hours, the child just becomes exhausted, but the child does not become unconscious after that. And frequently, as shown in the first video, the child tries to fight these movements because these are a little painful and these are against the child's voluntary movements, but the child tries to make voluntary movements alongside. This cannot happen with a true seizure, and this is treated with sedatives and anti-dystonia agents. Anti-seizure medications, for example, the sodium channel blockers, including phenytoin and carbamazepine and all that, can worsen this because of central mechanism. So this should not be used. So this is a 1.5-year-old child with these movements since the last 1 month. Again, these are very common. A child who's active, playful, suddenly has this grimacing of the face and some, stiffening of the limbs. And child is quite comfortable after that, continues playing. Does this many times. Again, he does this. Yeah. So parents are worried. They come to the pediatrician or pediatric neurologist. So these are shuddering attacks which are quite common in infancy. These are 3 children. The first one I showed, this video, is that of a typical shuddering attack, a typical shudder. But shuddering attacks can take many forms as seen in these 3 children. So the first child is one with, very quick shudder and a head drop. Yeah. So it's not a very typical shudder, but yes, it is also shuddering. This is a spectrum again. The child is well playful, the child is not affected by this movement, but well, the parents and grandparents are. So quick stiffening, there is some head drop as well. And in this child, more of, facial grimacing, which is worrisome. Yeah. There is some stiffening also, but the child, has this facial grimacing which brought them to the doctor. Yeah, this facial grimacing. Yeah. And in this child, third child who's actively, interacting and laughing, you can see that suddenly the child drops her head. Yeah. 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 This is a head drop. No limb movements, not typical shudder. So this can be called benign atonic head drops. Yeah. So this is again comes under the shuddering spectrum. This is now called uh, these are now called transient infant movements or transient benign paroxysmal disorders of infancy. Again, these are benign, self-limiting, idiopathic. They're seen in the second part, that is 6 months to around 12 months of life. They're triggered by food, excitement. Particularly, parents give this history of when the child is being fed, a child is playing with the father or playing with a relative, the child, in excitement throws these kinds of movements, or in frustration. It is easily distractible by changing the behavioral state. Pick the child up, show him something interesting, the child stops doing it, and it ceases by the second year of life invariably. So one thing which pediatricians are generally worried about is an infantile spasm, which can look like this, but the differentiating features are that there are no abnormal eye movements, there is no uprolling, and this is the shuddering attack is not a very unpleasant movement, whereas a spasm is a seemingly painful and unpleasant movement. So there is crying during these episodes in a spasm, and development obviously is normal, and there is no diurnal variation in the sense that infantile spasms are more common just before going to sleep or just after the child wakes up from sleep, with the latter being more common. So this is a child who's having, infantile spasms, a child who's developmental delay due to perinatal brain insult. You can see that the child is just going to go into a spasm. Yeah. And there is sudden uprolling, very quick movement. If you blink, you will miss it. So the child has a sudden uprolling and there is a stiffening of the limb. The child is crying. He's quite, distressed by this movement. And again, a few seconds later, he has it again. The child is not very comfortable with these movements, right? So this occurs in clusters, particularly after the child wakes up from sleep. And this is a typical infantile or epileptic spasm. And this is how you differentiate them from the benign shuddering spell. So a 16-year-old athlete who was referred for abnormal arm twisting movements after starting to run since the last 4 years. So this is the boy who starts running apparently well. But what happens? Suddenly he starts having some abnormal twisting movements of the right upper limb. and then he drops down, and slowly the neck is involved and the right upper limb is involved. He twists over himself, and then this is over in a few seconds. The child gets up, continues his sprint. Yeah, now he's totally fine. So he then gets up and starts running in this video. Yeah. So this is again a genetic condition. It is paroxysmal kinesogenic dyskinesia, similar to the one which described previously. That was exercise induced, that occurs after a significant duration of exercise and fasting. But this occurs after a quick movement, such as starting to sprint or, starting to run after sitting for a long time. It's more common in the second decade of life, more common in males. Sudden brief dystonia of one limb then frequently involves the other as well, and it lasts not more than a few seconds. It is due to a pathogenic variant in the PRR2 gene. It is eminently treatable with a very small dose of a sodium channel blocker, including carbamazepine or phenytoin, much lower than the doses which we use to treat, seizures. It spontaneously remits in the fourth decade, so there's nothing in the long term to be worried about. My last few slides. So these are two infants, one a boy, one a girl. With these movements, parents were worried. The first one is that of a girl, the second one is that of a boy. When the child is left alone, when the child is bored, the child keeps doing this. So again, this is quite common. Most of you might have recognized this. It can be a little subtle in girls for the reasons which I'll be telling now. These are self-gratification or infantile masturbatory movements. This is common, around 2 years of age. Females, it's more subtle, so it's quite difficult to diagnose because external genitalia are not very easily accessible for manipulation. This is stereotyped posturing with pressure frequently applied to the pubic area in some form or the other. If you can observe the child's face during these events, there is some quiet grunting, diaphoresis, or facial flushing. So this is a self-soothing behavior. This can last for a few hours if the child is left to himself or herself. There is no alteration of consciousness, and you can distract them or engage them in something, and this stops. So the only thing which parents need to hear and we need to say is that there is no association with sexual thoughts. It is a self-comforting behavior akin to thumb sucking, and this relieves the anxiety of parents, and this goes away after a few years. So my last case is that of a boy who was 1.5 years when he started having this abnormal eye movements, especially when he gets a URI with a low-grade fever. Suddenly eyes goes up, but he's totally conscious. He keeps playing, he keeps talking. The mother is making the video, the father is holding him. He tries to look at the mother, but he's not able to look down. He's just looking up. And if he wants to look down, he has to, move his head down. Yeah, because his eyes are fixed in tonic upgaze. So the name gives away the diagnosis. So it is paroxysmal tonic upgaze of infancy. It is again a benign condition. It can last for a few hours even, but it is frequently precipitated by fatigue or fever or infections. Is repeated episodes of upgaze deviation. Horizontal eye movements are intact in these patients, and if you want to abort this, put the child to sleep. It goes away and then it comes back until the febrile infection is over. Why this occurs, no one really knows, but it is again self-resolving. It is of unknown etiology. And some children have developmental delay and gait problems, but this ceases to be a problem after the first few years of life. So I thank the organizers for this opportunity. I take this chance to invite you all for the first National Pediatric Neurocritical Care Update, which we're organizing in Chennai on 31st of August. You can check this link or WhatsApp me on this number or email me. Registrations are actively going on. Thank you.
Thank you, Dr. Shivan Keshavan, for that excellent session. I think you spoke on non-epileptic events, but I think most of the audience are quite dazed by that illustrative videos, and we are in a state of post-ictal depression now. So we'll probably give you a couple of minutes to relax and get back your breath so that we can take the discussion forward. We welcome on board our co-panelist for today's evening discussion, Dr. Sudhakar Karnakaran, who's currently a consultant in pediatric neurology in the Department of Pediatrics at Kobe Medical Center, Coimbatore. He did his MBBS from Tanjore Medical College, then went on to complete his MD from Uttar Pradesh, and then went on to do his DM from Sri Chitra, and has worked in various capacities at Christian Medical College, Vellore, then at PSG Institutes of Medical Science Research at Coimbatore, and he's been with us at KMCH for the past couple of years. We welcome you once again, Dr. Sudhakar. If you're ready, we will have a couple of questions posed to you, and then Dr. Shivan can also take part. Dr. Sudhakar, like we have in the urine culture, a lot of time is spent trying to explain to the parents the proper technique to collect urine so that the interpretation of the urine culture is appropriate. Similarly, one of the commonest investigations that a pediatrician does in pediatric neurology in a child with a seizure or a pseudo seizure is an EEG. Can you please tell us what are the basic components of a complete EEG so that the interpretation is comprehensive?
Okay, sir. Thanks for the introduction, sir. And congratulations to Dr. Shiv Keswan for that wonderful talk. He covered almost all the seizure mimics in 30 minutes. And coming back to the question, sir. Your question was about the basics of EEG, right, sir? About
What is no, whether we should have a awake EEG or a sleep EEG, how many leads should be included? What makes a completely comprehensive EEG study? That is a question.
Sir, a comprehensive EEG should have both awake and sleep EEG both together, sir. And a minimum of 20 minutes of awake EEG and 20 minutes of sleep EEG. This almost with the activation procedures like hyperventilation, photic stimulation, eye closure, eye opening, and with these activation procedure with a total of almost 1 hour. So this makes a complete EEG. Sometimes when the child is not cooperative, sometimes these only awake records are being done, but definitely for some of the epilepsy syndromes like Rolandic epilepsy, which is called as selects nowadays, and like Panetopolar syndrome and CSWS, these are some of the syndromes which will have epileptic pattern only in the sleep. And even West syndrome beginning stage, the epilepsy pattern may be picked up only in the sleep. So this makes a point that sleep EEG is mandatory.
Okay, thank you. Thanks for that comment. The next part about the EEG is some more questions on EEG because this is what we as practicing generalists feel very lost out. Very often we are forced to give an anticonvulsant, sometime like a short-acting anti-seizure medication like a nasal midazolam or a oral benzodiazepine. Does it actually affect the quality of the EEG study? If so, how many minutes or how many days should elapse between the giving of the drug and the study?
So the drugs definitely have an effect on the EEG, sir. If the child is on benzodiazepine, there are some specific patterns, and immediately after the seizures, there will be post-ictal slowing. So these changes has to be taken into consideration during interpretation. But in practical scenarios, for these purposes, the management and treatment purpose part should be the essential thing, because intraictal EEGs will also give the necessary informations for the epilepsy syndromes even in the later days also. And the initial 2 to 3 days we can expect this post-ictal slowing immediately after the seizures. And when the child is given benzodiazepines after a loading dose of any drug like phenytoin or valproate, definitely we may miss the seizure pattern. Like the intraictal phenomena, the spike and wave pattern may be abolished after the loading of drugs. So diagnostic aid will not be there. But practically, this is a theory thing. But practically, management and later intraictal record also can give us a fair idea. So this should not make us differ from the management part. So that's the crux I would like to say.
Okay. Now, very often we are not able to record an EEG during the ictal event unless the child has got status epilepticus or it's a newborn who's got a perinatal asphyxial injury with hypoxemic ischemic injury and there is an ongoing seizure activity or we are cooling the child. So very often in pediatrics, especially in the OPD, we are forced to do only a interictal EEG. So what is the optimal time to do the EEG after a seizure event? Let us assume that the child comes with a history of a paroxysmal unwitnessed event, which the class teacher reports as a seizure. The child is brought on Friday, and the history has been that this event happened on Wednesday. So, is there an optimal time interval between the event and the EEG, or if you delay the EEG, it'll miss the diagnosis. Is there something like that?
Sir, the epilepsy syndrome is something that the spike and wave will be always if it is an absence epilepsy, you can see the spike and wave at any point of time. So the time really does not matter, sir. The time does not really matter. Only thing is we should be careful during interpretation, because this post-ictal slowing, which would happen immediately after the seizure, may result in some misinterpretation. So only that part has to be taken care. But apart from that, I don't think the timing of EEG will make the diagnosis, will alter the diagnosis, or will change the yield. The timing really does not matter, sir.
Okay. So while on the subject of EEG will be the last question before we go on to a bit of therapeutics. Is it a correct practice to treat the EEG and not the child? There are lots of times when the patient obviously doesn't have a seizure disorder, but the EEG is reported by a neurologist as abnormal with sharp wave discharges or abnormal intraepileptic discharges reported. When the clinical history is not correlating, are we medico-legally comfortable as a general pediatrician in not offering therapy? I have done a physical examination. I've taken a history. I've looked at the family history. I've done a thorough physical. I'm not convinced this child has got a seizure disorder. But the EEG by a competent neurologist says this EEG is showing ictal discharges. How do we go about this case scenario?
Sir, in this, I would like to say, even in epilepsy, 10% of the epilepsy cases, EEG will be normal. Though the vice versa is also true. So that means even in a normal child, in 3% of the general population in normal thing, there will be EEG or epilepsy abnormality or EEG traits. That means the child may not throw seizures, but they will have some abnormalities, and these abnormalities may be seen even with increased frequency with kids with autism and ADHD. So abnormalities should not be treated if the child does not have any clinical seizures, and if you do not see any clinical correlation. So we should not treat the EEG reports, and we should treat only clinically, sir.
Perfect. Thank you so much. Dr. Keshavan, are you available to take questions?
Yes, sir. Definitely, sir.
Perfectly. Thanks. So can you please tell us, of late, there seems to be a gradual shift. I mean, when we started our careers, we had nothing but phenobarbital and phenytoin, and the rare patient would be probably upgraded to sodium valproate. Now we have a bewildering choice of anti-seizure medications available. And we also keep talking about the potential for the anti-seizure medications themselves to cause a bit of injury to the growing brain. So we are very often seen perinatally asphyxiated infants, newborns being given phenobarbital or variably sodium valproate or phenytoin or levetiracetam, depending on the institutional practice. So when we start managing this child on OP basis, when the child is discharged, what is the minimum period of time that you would treat with anti-seizure medications in a child who's had a hypoxic ischemic injury? And what drug would be the least brain injurious?
Right, sir. Regarding the time duration, we have shifted from a period of, a few months to years to weeks to days now. So as soon as acute seizure in the context of a newborn having seizures due to hypoxic ischemic encephalopathy, as soon as acute seizure period is over, the current recommendation is to stop medications right away, not to continue them. Previously, we used to continue them for a month to 3 months. It was variable. Some guidelines said that people need to do a neurological examination when the child comes for follow-up in the early newborn period. And if the child is going to be neurologically normal, you can stop it, or else you will have to wait. Some people do an EEG, and depending on that, they make a decision. But the current recommendation is that you control the acute flurry of seizures, both electrical as well as clinical seizures. Newborn is one age group where we treat electrical seizures we consider electrical seizures to be more important than abnormal clinical movements because there are a lot of paroxysmal non-epileptic newborn movements in the newborn, whereas once you have an EEG correlate, that becomes more significant. And there are, that there is in the newborn, there is a lot of clinical asynchrony, or so this is very common that we have a lot of electrical seizures, but not much of, clinical seizures. So you treat the EEG in the newborn period, particularly during HIE. That is why the recommendation is to have a continuous EEG monitoring in the form of an amplitude integrated EEG in the newborn intensive care unit. So the current consensus is that control the acute seizures, stop the medication, do not continue them at discharge. And regarding the choice of medications, again, opinion is divided. There is no consensus on this. Initially, it was thought that, phenobarbital causes a lot of, neuronal apoptosis, and this may affect the long-term neurological outcome of the child. But again, evidence is divided on this. So levetrestam was brought in as a possible option, but current evidence says that phenobarbital still, as far as efficacy is concerned, phenobarbital is considered to be the most efficacious drug, even when compared to levetrestam. So it still remains the drug of choice as the first line agent for treatment of neonatal seizures, particularly in the context of hypoxic ischemic encephalopathy. Though this problem of, neurological damage to the growing newborn brain is still unsettled, I would still say phenobarbital is the drug of choice in the newborn period.
Yeah, thanks for that clarification. Now, one of the common problems that a practicing pediatrician feels is a child who's come with a first episode of seizure, unprovoked. Clinical exam normal. Now he's in a conundrum because parents are very anxious. They want to know what is the best option available to them to prevent another attack. So, as a pediatrician in the OPD, and what indications would I wait, and on what indications would I start an anti-seizure medication at the first episode of unprovoked seizure?
Yes, sir. Should I answer that, sir?
Yeah, please.
Yes. So it is justified if a general pediatrician does not start anti-seizure medication at the first seizure, but there are certain exceptions which one can remember. So if a child has a predisposing underlying condition which we very well know that the child is going to have recurrent seizures, like that of a child with cerebral palsy, like that of a child with probably autism spectrum disorder, which again is an underlying neurological problem. The child has one seizure, it is very likely the child is going to have another seizure. So, or the examination, neurological examination is abnormal, particularly in the case of, children with newborn brain insults, perinatal brain insults, as in the context of cerebral palsy, has microcephaly, has weakness on one side in the form of hemiplegic cerebral palsy. So in any abnormal neurological examination or an underlying diagnosis, for example, a child with tuberous sclerosis coming to you with the first seizure, though it is a first seizure, and a textbook recommendation would be not to start an anti-seizure medication, but that the child has, ash leaf macules, and the child has probable diagnosis of tuberous sclerosis. So once you are convinced, there is nothing wrong in starting anti-seizure medications. But overall, in a child who is developmentally normal, whose neurological examination is normal, the child has just one unprovoked seizure, particularly if it is very brief. If the first seizure itself is going to be a status, or a child who's going to be admitted in the PICU, and child is going to stay there for a while, you don't want another seizure to occur, at least for the next 2 years. So again, starting anti-seizure medications wouldn't be questioned. So these are the 3 or 4 indications where you are justified in starting an anti-seizure medication right away. But otherwise, overall, the general principle still holds good, that if a first unprovoked seizure comes, you evaluate, but you need not start an anticonvulsant.
So at what point do we actually call it an epilepsy and consider starting anti-seizure medication? Sub-question is, would the previously held concepts that you've given us apply to focal seizures as well?
Right, sir. So a child initially the definition was that the child, if he or she has 2 unprovoked seizures separated 24 hours apart, then that constitutes an epilepsy. But now the definition has been modified. If the child has an underlying predisposition that the child may throw a second seizure after the first seizure, then you are justified to call it epilepsy right away. So they say that if there is a 60% chance, I don't know how they calculate, but this is what is given by the ILAE, the International League Against Epilepsy, that if there is a 60% chance at the time point when the child has, been diagnosed with the first seizure, that the child will have another seizure, you can call him epilepsy. So a child, for example, a child with, tuberous sclerosis with tumors in the brain definitely has a more than 60% chance that he'll throw a seizure. So you are justified starting. So that is yes. And this definition holds good for a focal seizure as well, sir.
Okay. And Dr. Sudhakar.
Yeah. Yes.
So what are the indications for doing neuroimaging? And is there any point in today's medicine, especially in the context of MRI being available at most tier 2, tier 3 places also? Is there a place for CT scan still, or would we do an MRI? If we do an MRI, what is so special about this MRI epilepsy protocol that people keep talking about? Would a plain MRI not be enough? So are there modifications of the MRI that you would insist on as a neurologist in the workup of a child with seizure?
Okay, sir. When a child comes, first you are seeing whether it's an unprovoked seizure and the child qualifies to be called as epileptic. Then after that, you try to find out whether the child is fitting into some pattern of epilepsy syndrome. Like if a child is fitting into a typical pattern based on the semiology and EEG of an absence epilepsy, the child does not warrant imaging. The neurological examination normal and childhood absence epilepsy, then it's a full stop. That's no need for an MRI brain. But during if the child has a semiology of focal seizure and a possibility of structural causes being suspected in a child, definitely the child will need an MRI. So it all depends on the what is the etiology suspicion in that case scenario. And if structural cause is more suspected, definitely the child will need a MRI. And MRI epilepsy protocol is preferred. CT at this point of time will not be helpful for epilepsy management because epilepsy protocol MRI, the 3T MRI is done with the specific cuts in the hippocampus to not to miss the hippocampal sclerosis, not to miss the focal cortical dysplasias, which are some of the common structural causes in the infant and pediatric epilepsies. So these thin cuts will not miss these diagnoses, these structural causes. The CT or routine MRI may miss these causes, and we may land up with a focal epilepsy without any yield on the imaging. So that's why a 3T MRI epilepsy protocol is always preferred, sir.
Okay. So coming to the last couple of questions on seizures before we gravitate towards headache. Is it mandatory to do an EEG at the end of the treatment schedule? At the end of the prescribed, you have said 2 years seizure-free period, the EEG is done. The EEG is normal, we are comfortable, parents are comfortable. But suppose at the end of a clinical event-free period of 2 years, the EEG is reported as the same that we started the anti-seizure medications. Parents are very dejected because most of them are literate enough to read the EEG report, and they see that the EEG is not changed at all. In such a situation, should we be comfortable stopping the seizure medications, or should we be offering some more continuation of care because the EEG is not normalized?
Yes. Sir, this stoppage of medicine, the main deciding factor is the etiology of the epilepsy, sir. So if the etiology is it's a structural cause, then definitely we need not expect a normal EEG at the end of 2 years.
Mm-hmm.
So 2 years rule holds true for only some self-limited focal epilepsies in childhood, like this Rolandic epilepsies, childhood absence epilepsies. So you may see by the end of 2.5 to 3 years, you may see a normal EEG. But rest of the cases, if there is a structural cause, you are not going to see unless the cause is addressed. You are not going to see a normal
I'm
EEG.
talking about the common garden variety, the idiopathic generalized epilepsy, which is what a general pediatrician sees most commonly. I'm talking about common garden variety, idiopathic generalized epilepsy, abnormal
Yes.
EEG, 2 years of treatment, neurologically normal child, seizure free. At the end of 2 years, we still have an abnormal EEG. Shall we stop? Shall we continue?
Sir, even in this the genetic generalized epilepsy, some patterns like juvenile absence epilepsy, juvenile myoclonic epilepsy, definitely lifelong medicines are advised, and you may not see a normal EEG even after 2 years, sir. Even even in this genetic generally epilepsy groups, only this childhood absence epilepsy and benign Rolandic epilepsies, there you may see a normal EEG after 2.5 years. So even within the genetic generalist group, it all depends on the which epilepsy syndrome the child fits in.
So would you wait for 2 years, do an EEG at the end of the therapy, or should we not? Because the decision seems to be not based on the EEG. Is it advisable at all to do the EEG at the end of the treatment period?
Sir, if after 2 years, and if the based on the epilepsy syndrome after 2 years, if the EEG is abnormal, definitely I will not advise stopping the medicine, sir. I will advise for continuation only. And duration 2 to 3 years is it's not a fixed thing, and it should be individualized for the child. And you have to continue it for the next at least 2 years. Then you may repeat, and it all depends on how in which epilepsy syndrome the child falls in, because sometimes for juvenile absence and juvenile myoclonic, I end up at most continuing a low dose medications at least for 10 years. 10 years. Some may need even lifelong.
No, I mean, do you mean to tell that after 2 years in a perfectly normal child, if the EEG is abnormal, you will continue and evaluate, send for evaluation, or you keep continuing also the drugs?
Yeah, see, if the child fits into the syndrome, what the initial diagnosis we have made,
No,
there
but
is no.
generally a pediatrician with an MRI normal and the EEG is going to be abnormal. We don't make a syndromic diagnosis at that stage. Right? We don't send for even neurological evaluation, and we started off in our clinical practice. In that condition, after 2 years, EEG comes as abnormal. Do you expect us to again send it for a syndromic diagnosis, go for a genetic evaluation, or we keep continuing the medicines?
Yeah, if diagnosis is unclear, definitely I would suggest to go for the epilepsy characterization and epilepsy syndrome workup. Definitely, I would advise for that, ma'am.
And
Because nowadays,
last question on seizures. Sorry, Embo.
yes,
Please
sir.
continue.
Yeah.
No, please continue. You were saying something.
Yes, sir. And nowadays we have for epilepsy workup, we are having so much of armament in the workup. We have genetic workups which have a yield of the whole exome sequencing has a yield of around 40 to 50% in the infantile epilepsies. So this genetic workup and even in those scenarios, this video EEGs and video EEGs will be definitely helpful. And in case PETs can also may be helpful. So at any cost, we would try to reach at etiology and or the epilepsy syndrome characterization. So that would be that I would suggest if the EEG is still going abnormal.
Okay.
Are there any non-pharmacological adjuncts to treatment of seizures? And if we decide to stop anti-seizure medication, should be tapered and stopped, or can we stop it abruptly?
So regarding stoppage, there is no definite consensus for to be tapered or something like that, sir. If the child crosses that period and if the plan is to stop, we can stop even abruptly also. There is no consensus to you have to only taper and stop. There is nothing like that. But we should be very careful with phenobarbital, as there may be withdrawal seizures if the child is on long-term phenobarbital. But apart from that, for other drugs, the stopping abruptly is not going to be harmful.
Okay. For a person who's practicing in the periphery, who is not having the services of a Dr. Sudhakar or Dr. Shivan Keshavan, if he's not really able to make up his mind, would you suggest a general all-purpose anti-seizure medication that is safe and which will cover most seizure disorders? Because that's what ultimately all of us want to know. One
Yes, sir.
Ravindra Jadeja, one all-rounder which I can use for virtually every seizure with the fear, with the hope that it will not worsen the clinical condition. It may not help, but definitely it won't harm the child. Is there such a wonder drug?
Sir, this scenario, yeah, the medication should be broad spectrum. That means it should take care of both generalized seizure and focal seizure. That's point number one. And point number two, there should be very less drug interactions. Point number three, the drug therapeutic level should be reached immediately. The loading after it should have a loading dose. So all these criteria would be fit by the levetiracetam first. Levetiracetam and valproate, if at all the information regarding whether it is a focal onset or generalized is not known, and I levetiracetam would be the if these informations are not clear, levetiracetam would be ideal as it fits into all these criteria what I told before, sir. Only thing is we should be careful with ADHD kids as it may aggravate the behavioral issues. In those scenarios, valproate also will be an ideal choice. If at all levetiracetam cannot be chosen.
Okay, thanks for that clear reply. Dr. Shivan,
Yes, sir.
we have come to a point where now instead of Jadagams, we'll be exchanging whole exome sequencing reports of the prospective bride and groom. That is the degree to which we are doing genetic studies. But as a neurologist, under what conditions do you want us to consider doing a genetic evaluation of a child with a seizure disorder?
Yes, sir. So the first thing is that when you suspect something to be a genetic in etiology, you go for a genetic test. So I would say in children who less than 1 or 2 years of age with an undiagnosed epilepsy, you think of a genetic test. As a broad recommendation, this would hold good, particularly infantile epilepsy. You suspect that the MRI is normal, the child is, you don't have a really a cause for the epilepsy, then it is the likelihood of finding something abnormal or reaching a diagnosis on genetic testing is high. As he had mentioned, the figures are 40, 50, and even more than that. So in other circumstances, you do a genetic test very sparingly, only when it is strongly indicated. For example, a child with tuberous sclerosis, not really fitting into the criteria, not able to make a diagnosis at any age. If you test his DNA for the mutation in the involved gene, you will get the pathogenic variant. So that will help you in making a diagnosis. So beyond that, you don't really do a genetic test as a blanket investigation for children who are epileptic or have epilepsy. But in the infantile epilepsy age group, you do a genetic test, and the yield of a genetic test in a particular index child with epilepsy is higher if the child has an underlying developmental delay, if the age is less than 2 or 3 years of age, particularly less than 1 year of age. And in addition, if you have any other unexplained, at least one unexplained neurological symptom, such as, you have dystonia or chorea, you have a movement disorder, you have some other abnormality, then that increases the yield of you finding a genetic diagnosis. So as a rule, probably these would hold good.
Right. Now we have been repeatedly told like Montelukast can cause headaches, suicidal ideations, yet it continues to be widely used, and most people who have used Montelukast for long periods swear by its safety as well as its efficacy. So obviously there is a disparity between what is written in the literature and what we actually see in practice. Similarly, a lot has been told about the behavioral effects of levetiracetam, but Dr. Sudhakar said that's his go-to medicines. It's like Jasprit Bumrah will be given the ball every time we need a wicket, and he hardly ever fails us. So now we understand that brivaracetam seems to be even having a safer side effect profile compared to levetiracetam. Should brivaracetam be the preferred drug if you at all you desire to use levetiracetam? What's your take on that?
So is it for me, sir?
Yeah, sure.
Yeah. So brivaracetam is said to have lesser neuropsychiatric adverse effects than levetiracetam. In practice, with the limited experience I have, I would say this doesn't make much of a difference. Both drugs, are used. Brivaracetam is used more commonly now, increasingly more commonly now than levetiracetam. But these behavioral side effects which we see in these children are in the initial part of the introduction of the drug, particularly when they are loaded and they're giving a high dose, particularly intravenously. And later on, in many of these children in practice, I've seen they become better. So if at all you have a condition where you have to use this drug, just for the initial period, I think if you bear with these adverse effects, it generally goes away. And many practitioners swear by brivaracetam that it is a better drug. particularly probably adult physicians and adult neurologists. But I would say that both drugs have a similar side effect profile. Slightly, breverestam has lesser neuropsychiatric side effects, yes. But all these are a problem in the first few weeks or days after introduction of the drug. And as we've already Dr. Sudhakar has already told, in children with neurodevelopmental disorders, particularly the autism spectrum, ADHD, we don't use this because they are much more prone to have to experience these adverse effects. In the other, we have many patients who are allergic to many of the sodium channel blockers, including oxcarbazepine, carbazepine, phenytoin, and all that. So in those patients, we have many patients who are on long-term levetrestam or breverestam and are doing well. So the initial part, high dose intravenous preparation, we see a lot of problems. And in those predisposed patients to have behavioral problems, such as children with hyperactivity and children who have speech delay and suspected autism spectrum, we generally prefer not to use it. In the other, there is one group which really benefit from levetrestam, particularly those with allergies and focal epilepsy. And there is one group of patients categorized as juvenile myoclonic epilepsy, particularly girls, idiopathic generalized epilepsy, children who have only GTCs in the morning. Particularly girls, we don't use the drug of choice in those epilepsies. Otherwise, that is sodium valproate, because of the other reproductive adverse effects which are worried about. In those patients, levetrestam is a very good drug. In the initial part, if you may have a few, stumbling blocks, but later on they do good, particularly when the dose is not too high. So again, high dose, intravenous, initial few weeks, and predisposed population, we don't, prefer levetrestam. And breverestam versus levetrestam, slight advantage, but I wouldn't say that in pediatrics it matters much as much as I know about it.
Thank you. We are now coming to the last 10 or 15 minutes of today's show. So I'm sure that the audience has most of the queries regarding seizure mimics address. So we have given disproportionately more time because this is one of the pressing issues where I thought more clarity would be required. Over the next 10-15 minutes, we will probably take a couple of questions on the OP management of headache. Dr. Sudhakar,
Yes, sir.
Are you going to take the questions given by some of the people? It was.
I think most of the questions I have covered, Dr.
Yeah. No,
Narmada.
I think one question was very nicely asked by what are the common drugs which is causing oculogyric crisis? And
Dr.
that
Shiva?
causes seizures.
Yeah.
Seizure mimic?
Yes,
Yeah.
sir. So the most common two groups of drugs which cause these are, one is antiemetics, particularly metoclopramide, and the other groups of first generation antihistaminics and antidopaminergics, which are used as antiemetics. And the second is accidental ingestion or high dose of antipsychotics. Initially, it used to be haloperidol. Now, because we use a lot of risperidone and atypical antipsychotics in children with autism spectrum for irritability, that is again the most common. So these two groups are more common. But as I said, the oculogyric crisis is basically focal dystonia of the extraocular muscles. So again, as I told in my presentation, sodium channel blockers, including phenytoin and carbamazepine, can cause this, but this is not very common. So metoclopramide and risperidone top the list.
Okay. And there is one question on do you prefer pertussis vaccine for neonatal seizures, HIE, cerebral palsy?
Can I answer that, ma'am?
Yeah. Please.
Yes.
Please.
Yeah. So we do not defer any vaccination for any patient with any form of epilepsy. The only patients which we are worried about because they may have prolonged status epilepticus after a febrile illness, be it after a vaccine or without a vaccine because of a viral, URI or any gastroenteritis or anything like that, are those children with something called Dravet syndrome, which is a sodium channel mutation. So in these patients, if they're properly medicated and given clobazam prophylaxis, we are not going to defer any vaccine for them. So vaccine, as we all know, vaccination is a life-saving measure. So as a rule, no vaccine is contraindicated for any child with any neurometabolic disorder or a genetic epilepsy.
Thank you so much.
Dr. Chandya has asked a question on the difference between opsoclonus and ocular tics. She has repeated the question. Can you please answer that?
All right, sir. So that's a very good question. Many times it becomes difficult to really categorize between these two phenomenologically. But otherwise, with the friends that they come with, we can very well identify them, because opsoclonus is going to be seen in smaller children, particularly those in toddlerhood or infancy or invariably less than 5 years of age. with excessive irritability, ataxia, myoclonus, which are all not going to occur in children with ocular tics, which I had already told you that ocular tics occur in children invariably with other facial tics as well. And those are children usually above the age of 5 years, though we can see in smaller children as well. So you generally see around 5, 6, 7, 8, 9, 10, something like that. And phenomenologically, it is very difficult because both are erratic, both are irregular, both are very chaotic, multi-directional and all that. But two phenomena are very important. Ocular tics are have an urge and they are suppressible and distractible, whereas opsoclonus is something which is not under the control of the child. It is from the certain neurons in the brainstem which is going to discharge erratically at irregular intervals. So you cannot do anything to that. So these are the two things which which you can use to differentiate between the two.
Thank you so much. That was a very clear explanation. Ashwat, over to you for further.
No, I think we will not have enough time to take up headaches. So while
I
on the
think,
subject of seizures, I think next 5 minutes we will take a couple of more questions on seizures and wind up the session. Dr. Sudhakar.
2 or 3 practical points for headache. Ashwat.
Correct. So Nelson's textbook of pediatrics continues to not recommend clobazam for intermittent prophylaxis in children with febrile seizures. However, we continue to use the IAP position paper continues to advocate the use. What's your take on it? Does clobazam work, or is it just an expensive placebo that we feel comfortable and the parents feel comfortable that they have given something to prevent the recurrence of a febrile seizure? Does it actually work?
Sir, in the long term, it is not going to work, sir. In the long term, the risk outweighs the benefits.
No, I'm talking about intermittent prophylaxis. After the
Yes, sir.
first episode of a typical febrile seizure, we commonly keep giving them clobazam, right? For the first 72 hours. That's what the IAP practice parameter says. So Nelson's doesn't, after so many editions, there is no mention of that word at all. So why is it so important for us to use a drug which the Bhagavad Gita of pediatrics doesn't recommend? That's my point.
Sir, even intermittent is not going to be so much effective. But the thing is, if the parents are very anxious and if the parents are very
All our
anxious,
patients are anxious. All our parents are anxious.
yes, sir. Actually, this is a scientific thing recommendation. What is told about if the parents are anxious, it's going to be of help. Intermittent things is going to be of help in during the onset of the febrile illness.
Mhm.
So this is the this should be the latest. I think Dr. Shivan will agree with me, because this is the latest. This meta-analysis on long-term anti-seizure medications on febrile seizures. So this says that even this intermittent febrile seizure prophylaxis does not have any role on the outcome of the child. But if the parents are anxious, this intermittent febrile seizure prophylaxis with clobazam or diazepam can be given. That's the latest evidence I could say regarding this febrile seizure prophylaxis, sir. So the ultimate thing is it does not say no for intermittent febrile seizure prophylaxis. That's what I will say.
Okay. So I think we have answered most questions. There was one question on non-pharmacological interventions raised by Dr. Kumar. Can you please take that question in the chat box? Non-pharmacological advice that you can give. Are there any triggers that you can tell the parent to avoid in a child with an idiopathic generalized seizure disorder?
Yes,
Are
sir.
there common triggers?
Yeah, sleep deprivation is one very common trigger. So definitely that will be told to the parents, and especially in the adolescents who they will be going for the exams. They suddenly throw seizures after a sleep deprived night. So sleep deprivation has to be addressed first. Number two, screen time, avoidance of the screen time. So there are many photoparoxysmal epilepsy syndromes. So with regard to that, the screen time has to be decreased. I think IAP has given the recommendation that would be fairly appropriate time. Yeah. So screen time and sleep deprivation, that's the most two important things I would say regarding the advices what to be given, sir.
So many of these anticonvulsants have adverse side effects on the liver functions and on the CBC. So is it mandatory to do a baseline CBC LFT before we start them on anti-seizure medications, especially phenytoin, phenopap, carbamazepine, sodium valproate with respect to liver function test. Is that a recommendation that you should do it before we start and keep repeating it as the child is on therapy?
So there is no recommendation to do for the general population, only for the special groups. Only for this, if you are suspecting some associated hematological abnormalities, or if you have some thrombocytopenias in the previous histories, then we definitely do the baseline before starting valproate. But apart from that, for the general guidelines, there is no recommendation to do it while starting, sir.
Okay. I think we have taken as many questions as possible on the subject of seizure mimics and seizures. We agree that it's a very vast topic and it is probably not justified on our part to expect 1 hour of even the best brains to address all the questions. I think we try to do justice to the topic. Let me wholeheartedly, on behalf of IAP TNSC, thanks once again for the platform created for the 4P series. I thanks once again both the speakers and the moderators for today's program, and Dr. Narmada, Dr. KR, Dr. Shingarvelu sir, about the support that the 4P series has been got. I'm sure all the audience who have logged in and who are listening to this show will leave the show much more enlightened than they were at the beginning. Thank you once again for both the panelists for being so patient with our too many queries and for giving very, very crystal clear answers and clearing most practical doubts when it comes to seizure and seizure mimics. Thanks once again. We wish all of you a good night.
You also for the very nice clinically oriented, practitioner oriented question.
Thank you.
That made it very interesting also. And before we complete, can we have a word from Dr. Srinivasan sir?
Why from Srinivasan? There are so many eminent people. Yeah. So wonderful. I have been listening, and no, it's a very important topic which has to be discussed, and all the good questions, will be well answered. And of course, it's a very important thing to make the parents comfortable besides giving treatment. Yeah. So everything was very well discussed, and we are very much enlightened. Thank you so much. I'm a bhakta for this thing, of these people. Yeah. Thank you.
Thank you so much, Dr. Shivan and Dr. Sitakar. Your knowledge was very clear concepts and clear discussions. It was really very
Absolutely.
Thank you so much.
Thank you so much, Ashwath, for choosing such an elite panel for discussion and having the moderation. Thank you all the delegates who stayed focused not only on this platform but also in YouTube. We had more joining in the YouTube, and we will have more of viewers in the upcoming days also. Thank Dr. Rajendra sir and Dr. Tirumurugan, the academic coordinator, for this platform and for such an enlightening talks. Thank you all for joining with us. See you again in the next academic session of 5.
Good night for all of you.
Good night, sir.
Good night. Thanks to APTNSC team once again. Thanks to both my panelists once again. Thank you so much.
Thank you so much, sir. Good night.
Thanks a lot, sir.